Welcome back to the deep dive. Today, we're really zoning in on something specific, but really important in pregnancy care: placenta previa.
That's right.
Think of this as us taking some, high-yield medical revision notes and sort of unpacking them together.
Exactly. We've got these detailed notes, the kind designed to give you the absolute key facts. And our job, really, is to pull out that crucial info, make it clear, and help it stick.
Yeah, whether you're actually revising for something like the MSRA or maybe you're just curious about this condition.
Because it is significant.
It really is. Understanding placenta previa, it's not just theoretical, right? It's about patient safety. The notes point out it's a major cause of complications and a top reason for bleeding late in pregnancy.
Antepartum bleeding, yeah.
Okay, so let's get into these notes, starting right at the beginning. What exactly is placenta previa?
Okay, so the notes define it pretty clearly. Placenta previa is when the placenta is lying partly or even wholly down in the lower segment of the uterus. And, often the term is used really specifically when it's lying directly over the internal os.
The internal os, that's the inside opening of the cervix.
That's the one, the way out, essentially.
Got it. So it's basically the placenta being positioned too low, near or covering the exit. But the notes also mention low-lying placenta. Is that different?
Yes, they make a useful distinction there. For pregnancies that are past 16 weeks, they say we call it low-lying if the edge of the placenta is within 20 millimeters of that internal os.
Okay, within 20 millimeters.
And that's measured specifically on a transvaginal ultrasound, or TVS.
TVS, using the internal probe for a better look.
Exactly. Gives you much better precision down there.
So previa is covering or right over the opening. Low-lying is close within that 20 millimeter zone after 16 weeks. And why does this matter so much? The notes stress the significance straight away.
Oh, absolutely. Clinically, it's huge. It's listed right up there as a major cause of complications for both mom and baby, and crucially, a top cause of antepartum hemorrhage.
Antepartum hemorrhage. Bleeding after 24 weeks, yeah?
That's it. Any bleeding from 24 weeks until delivery. And placenta previa is high on that list of possibilities.
Okay, a key thing to remember. So we know what it is, why it's serious, but why does it happen? Why does the placenta implant down there? What about the causes, the etiology, and risk factors in the notes?
Well, this is actually quite interesting. The notes state pretty directly that the precise cause, well, it's currently unknown.
Really? That's surprising for something so relatively common and significant.
It is. We know a lot about what increases the risk, but not the fundamental trigger necessarily.
Okay, so let's talk about those risk factors then. That must be key information from the notes.
Absolutely vital. For revision, you definitely want to know these associations. Top of the list, advanced maternal age.
Okay.
Then, a really big one, previous cesarean section. And the notes make a point of saying the risk goes up with each additional C-section.
Ah, that cumulative risk is a critical point, isn't it? Not just having had one, but more than one really bumps up the chances.
Exactly. It's dose-dependent, if you like. Other things include multiple pregnancies, like twins or triplets, any underlying uterine abnormalities, and perhaps unsurprisingly, a previous history of placenta previa itself.
Right, if it happened before.
You're more likely to have it again statistically.
Makes sense. What else is on that list?
The notes also mention lifestyle factors, smoking during pregnancy and cocaine use. And then there are things related to past procedures, like a previous spontaneous or induced abortion,
Okay.
and also having what's called deficient endometrium.
Deficient endometrium. What does that mean, according to the notes?
It means the lining of the uterus isn't quite optimal for implantation, perhaps. Examples they give are things like endometritis inflammation or maybe scarring from a previous procedure like a manual removal of the placenta or a curettage like a DNC.
Ah, okay. So anything that might have damaged or altered the uterine lining where the placenta attaches?
Pretty much. Issues with the implantation site itself. And the final risk factor listed is assisted conception, like IVF.
Wow, that's a really comprehensive list. Covers patient history, lifestyle, past procedures. So if the placenta does implant too low, how does that actually cause bleeding? The pathophysiology bit in the note.
Right. So the basic mechanism is straightforward. The placenta is attached low down, near, or over the cervix. Now, as the pregnancy progresses, particularly later on or when labor starts, that lower part of the uterus, the lower segment, it starts to thin out and stretch.
Yeah, getting ready for birth. The cervix effaces and dilates.
Precisely. And as that area stretches and changes shape, it pulls on the bit of placenta that's attached there. It disturbs the attachment.
Okay.
Think of it like a sticker on a balloon near the opening. As you blow the balloon up, the bit near the opening stretches the most, and the sticker might start to peel off at the edges.
This is a good visual.
That disruption tears the blood vessels connecting the placenta and the uterus right at that spot. And that's what causes the bleeding.
Okay, the stretching disturbs the low attachment, tears vessels. Got it. Now, bleeding in pregnancy is always worrying, but it isn't always Placenta Praevia. The notes have a section on differential diagnosis, right? What else needs to be on the radar?
Absolutely crucial, this bit. Clinically, when someone presents with bleeding in later pregnancy, you have to think, what could this be? The notes list the main contenders. Placental abruption is a really key one to differentiate.
Abruption. That's where the placenta comes away early, but from its normal higher position.
Exactly. Praevia is about location too low. Abruption is about separation too early from a normal spot. Big difference in management and often symptoms.
Right. Pain often being a key difference.
Generally, yes.
Yeah.
Come back to that. The notes also say don't forget to check for cervical or vaginal lesions. Sometimes the bleeding isn't from the uterus at all. It could be a polyp or an ectropion or even something more sinister, though rarer.
Good point. Don't jump to conclusions. So how common is Placenta Praevia? What do the notes say about epidemiology?
They give some UK-specific figures. Overall, it's estimated in about 1 in 200 pregnancies.
1 in 200. Okay, so quite significant.
Definitely common enough that you'll encounter it in obstetric practice. More specifically, they say it affects somewhere between 0.3% and 2% of pregnancies in the third trimester.
Okay, 0.3 to 2% by the third trimester. But you mentioned earlier it's often picked up.
Yes. This is a fascinating point in the notes. They state that actually about 5% of pregnancies show a low-lying placenta on that routine 16 to 20-week scan.
5%. But you just said 0.5% incidence at delivery in another section. That's a massive drop from 5% down to 0.5%.
It is a huge drop, and this highlights the concept of placental migration, or parent migration maybe is a better term.
Migration. Does the placenta actually move?
Not really crawl up the wall, no.
Oh.
What happens, the notes explain, is as the uterus grows massively during the second half of pregnancy, the lower uterine segment, that bottom part, elongates and develops. So the placenta stays attached to its original spot, but the uterine wall itself stretches upwards and away from the cervix, effectively carrying the placenta with it, further from the os.
Okay, that makes sense. It looks like it moved up, but it's actually the uterus growing beneath it, pulling it away from the cervix.
Exactly. It's more about the development of the lower segment.
Okay.
But the notes add a really important clinical tip here.
Oh, yeah.
This apparent migration is less likely to happen if the placenta is located on the posterior wall, the back wall of the uterus.
Oh.
Or, crucially, if the woman has had a previous C-section.
Right. So posterior placenta or previous C-section scar, the migration is less likely. Those need closer watching.
Definitely. Those factors seem to kind of fix the placenta lower down more often. It ties back into the risk factors we discussed. The notes also explicitly link the rising incidence of Placenta Praevia overall to the increasing rates of C-sections globally.
It all connects. Okay, so we know what it is, the risks, why it bleeds, what else it could be, how common it is, and this migration idea. What does it actually look like clinically? The features.
This is where we get to the classic textbook presentation. The notes really emphasize the hallmark symptom: painless vaginal bleeding.
Painless, that's the word they stress.
Absolutely key. Painless, usually starting in the second or more often the third trimester. And stressing it's painless is vital because, as you mentioned, it helps distinguish it from placental abruption, which typically causes significant pain.
Right. So painless bleeding. Think Praevia first. What's the bleeding like?
The notes describe it as bright red blood. Other features. Well, the degree of shock the mother might be in should be proportional to the visible blood loss. And again, reinforcing the difference with abruption. Usually no abdominal pain or uterine tenderness. The uterus often feels soft and non-tender on examination.
No pain, no tenderness. Soft uterus. Got it. What about the baby's position? Does it affect that?
It often does. Because the placenta is literally taking up space in the lower part of the uterus where the baby's head would normally engage, the notes say you often find an abnormal lie or presentation. The baby might be breech or transverse.
Because the placenta's in the way.
Exactly. It's physically obstructing the normal head-down position. Usually the fetal heart rate is normal, at least initially, unless the bleeding is very severe, causing maternal shock or fetal distress. And coagulation problems, issues with blood clotting, are rare with Praevia itself, unlike sometimes happens with severe abruption.
Okay. And the notes mention something about the pattern of bleeding sometimes.
Yes, they do mention that sometimes smaller bleeds can happen before a larger, more significant hemorrhage, sometimes called a sentinel bleed.
A sentinel blade.
It's like a
Warning shot.
kind of, yeah, a warning sign that things might escalate. So for revision, think painless, bright red bleeding, maybe an odd fetal position, maybe a small warning bleed first. But how is it actually found? Is it always because of bleeding?
Good question.
Well, the notes say very frequently it's actually found incidentally, picked up on a routine ultrasound scan, usually the 20-week anatomy scan.
So before any symptoms even start sometimes.
Often, yes, which is good because it allows for planning. And the notes also remind us there's an increased risk of preterm delivery associated with the Praevia, which makes sense if bleeding prompts earlier birth.
It does. Okay, so that leads nicely into investigations. How do we confirm it?
Right, the investigation section. And it kicks off with a massive critical warning.
Yes, this seems really important.
It is. The notes are emphatic. Avoid digital vaginal examination if you suspect placenta previa before you have an ultrasound result confirming the placenta's position.
Why is that so critical?
Because putting fingers into the vagina, potentially into the cervix, could directly poke the low-lying placenta and provoke torrential, potentially catastrophic bleeding. Is a huge no-no.
Okay, absolutely no internal exams until ultrasound rules out previa or confirms its location, a major safety point. So how do we diagnose it safely?
Ultrasound is the gold standard. As we said, often first suspected at the 20-week scan. But for the really accurate assessment, exactly how close is it? Does it cover the also and the yos? The notes strongly recommend transvaginal ultrasound, TVS.
The internal scan again?
Yeah, it just gives a much clearer, unambiguous view of that lower segment and the relationship between the placenta and the internal os. Much more accurate than transabdominal ultrasounds for this specific question.
Okay, TVS for precision. And the notes detail a grading system based on those findings to classify how bad it is.
Exactly. It was helped stratify the risk and guide management. The notes outline 4 grades.
The placenta dips into the lower segment but doesn't actually reach the internal os.
Okay. So
Grade. It reaches the edge of the internal os but doesn't cover it.
touching the edge.
Grade 3. It covers the internal os when the cervix is closed but might not cover it fully if the cervix were dilated. It partially covers it.
Partially covering.
And grade solve. This is the major or total placenta previa. It completely covers the internal os even when dilated.
Grade the 4th, totally blocked.
Yeah.
That sounds like the most problematic for delivery.
It generally is, yes. And this grading then informs the plan for follow-up scans, according to the notes.
Right. What's the usual follow-up?
If it's picked up low-lying at 20 weeks, the notes suggest a repeat scan around 32 weeks gestation.
To check for that migration.
Exactly. See if it's moved away. If it's still low at 32 weeks, say a grade 1 or 2 that's still close, they might recommend scans every couple of weeks after that. And then a final ultrasound is usually done around 36, 37 weeks to make the definitive plan for delivery mode and timing.
Okay.
For those who are asymptomatic, the notes specifically mention doing an additional TVS around 36 weeks just to be sure about the final position.
That makes sense. Always checking if it's moved up, but remembering, like we said.
Posterior placentas and those in women with previous C-sections are less likely to migrate. Need to keep that in mind.
Good memory aid. Posterior previous C-section, potentially persistent Praevia. Are there any other tests mentioned in the notes?
Yeah, a few others. They mention measuring cervical length on ultrasound sometimes, as a short cervix might increase the risk of preterm labor alongside the Praevia. Standard blood tests like a full blood count, FBC, to check hemoglobin for anemia. And crucially, getting blood cross-matched.
Cross-matching. Getting blood ready just in case.
Precisely. Sending samples to the blood bank so compatible blood is identified and readily available if a transfusion is needed urgently. And obviously, fetal monitoring CTGs to check how the baby is doing, especially if there's been any bleeding.
Okay. And if there is bleeding while they're figuring all this out?
The notes reiterate the immediate steps. Admit to hospital, use the ABC approach, airway, breathing, circulation, to stabilize the mother first and foremost, and consider an emergency C-section if things are unstable or bleeding is heavy.
Stabilize mom first. Always the priority, right? So we found it, maybe graded it. How do we manage it? The notes cover management strategies.
Yeah, and it's definitely tailored to the individual. The notes say management depends on things like the severity of any bleeding, the gestational age, how far along the pregnancy is, the condition of the mother and the baby, and other clinical factors.
Okay. What about those cases found incidentally on a scan with no bleeding? Asymptomatic cases.
For those, say, found at 32 weeks still low-lying but no bleeding, the note suggests counseling about warning signs, encouraging safety precautions like staying near the hospital and ensuring they have quick access to care if bleeding does start.
Makes sense. Any restrictions on activity?
Interestingly, the notes mention that generally for asymptomatic low-lying placenta found earlier, there aren't strict restrictions on activity or intercourse needed unless bleeding occurs. That's perhaps a bit more liberal than some older advice.
Good to have that specific clarification from the notes. Counseling must be key, though.
Absolutely. The notes stress the importance of discussing the risks, especially preterm delivery and major bleeding, obstetric hemorrhage, so the woman understands the situation fully.
Okay. What about actual medical treatments?
Well, antenatal corticosteroids are a big one, usually recommended between 34 and 35 plus 6 weeks gestation.
To mature the baby's lungs.
Exactly. In case the baby needs to be delivered early. The notes add they might be given earlier if the risk of preterm birth seems higher, like if there's been some bleeding already.
Okay. Steroids for lungs. Anything else?
Tocolysis, that's medication to stop or slow down uterine contractions, might be considered if there's bleeding in contractions, if the bleeding isn't too heavy, and the aim is to buy a bit more time. Maybe delay delivery for 48 hours to let the steroids work fully, but it's used cautiously.
Right. Only if stable enough. Okay. So steroids, maybe tocolytics. Then comes the actual delivery planning.
Yes, and this is critical. The notes state clearly, delivery must be planned for a maternity unit that has on-site blood transfusion services and critical care facilities. You need backup.
Essential for safety and the timing.
It depends on the specifics, but for uncomplicated placenta previa, meaning no major bleeds, mom and baby well, the notes suggest planning delivery typically between 36 plus 0 and 37 plus 0 weeks.
Yeah.
So, early term.
A bit earlier than the due date to avoid spontaneous labor and potential bleeding.
Exactly. Though they also mentioned that late preterm delivery between 34 and 36 plus 6 months might be considered if there are additional risk factors.
And the big question, how is the baby delivered?
Yeah.
Vaginal or C-section?
This goes back to the grading. The notes are quite clear. For grades 3 and 5 previa, where the placenta is significantly or totally covering the os, an elective cesarean section is the only safe option.
Because the exit is blocked.
Correct. That C-section is usually planned for around 37-38 weeks. However, for grade 4 previa, where the placenta is low but not reaching the os, the notes say a trial of vaginal delivery can be considered.
Okay, so grade might be okay for vaginal, but 3 and 4 definitely need a C-section. What if someone with known predia, like grade 4th, goes into labor before their planned C-section date?
Emergency cesarean section, immediately. The notes state that if labor starts spontaneously in someone with known significant placenta previa, attempting vaginal birth carries a very high risk of severe postpartum hemorrhage as the cervix dilates and the lower segment contracts. So it becomes an emergency C-section.
Right, no attempting vaginal birth if the path is not to be blocked. Let's just quickly recap the plan for managing really heavy acute bleeding, as the notes emphasize this.
Yeah, the emergency scenario. Number 1, immediate transfer to hospital. Number 2, absolutely NO vaginal examination. We can't stress that enough.
Keep saying it.
Assess the blood loss, get blood cross-matched and ready for transfusion. Stabilize the mother, first airway, breathing, circulation. Her condition is the priority before assessing the fetus in detail.
Mum first. Always.
Yes. And in cases of severe bleeding, surgical intervention is usually needed, meaning urgent delivery by emergency C-section. The notes also mention the possibility in severe, life-threatening hemorrhage that can't be controlled that a hysterectomy might be required as a life-saving measure.
Wow, okay, a stark reminder of the potential severity.
And if delivery isn't absolutely immediate but likely soon due to the bleeding, they might still give maternal steroids to give the baby's lungs a last-minute boost.
Okay, a very active escalating management for acute bleeds.
It has to be. The notes briefly touch on the fact that detailed management might also involve drugs to help the uterus contract, specific surgical techniques to control bleeding, and sometimes even interventional radiology procedures to block bleeding vessels.
Right, a multidisciplinary effort for severe cases.
Yeah.
So that covers how we find it and manage it. What about the outcomes? The prognosis?
The notes say, quite rightly, that the prognosis varies a lot. Depends on the grade of previa, how early it presented, if there were major bleeds, the gestational age at delivery, and the overall health of mother and baby.
But is there a general outlook?
Yes, the notes do offer reassurance. With appropriate management, careful monitoring, planned delivery, usually C-section, in a suitable hospital, most women with placenta previa deliver healthy babies. That's the positive message.
That's good to hear.
However, they immediately follow that by stressing the increased risks of certain complications are very real, especially excessive bleeding and preterm birth.
And the notes back this up with some quite sobering statistics from studies, don't they?
They do. These numbers really ground the discussion in reality. One study they mentioned found that over 42% of women with Pravia experience bleeding before delivery antepartum hemorrhage.
Well, nearly half.
And over 7% had significant bleeding after delivery postpartum hemorrhage. Maternal anemia was also common, affecting 30%, which makes sense with the bleeding risk.
Those bleeding figures are high. What about more serious outcomes?
Well, in that particular study, 5.2% required a hysterectomy. That's 1 in 20 women needing their uterus removed to control bleeding. That's significant.
Definitely.
And they also found that 4% had coexisting placenta accreta.
Accreta, where the placenta grows too deeply into the uterine wall, often linked to C-section scars.
Exactly. It's a major complication often found alongside Previa, especially with previous uterine surgery, and it massively increases the risk of severe hemorrhage and hysterectomy.
Okay, so accreta is a key associated risk. What about the babies?
The notes show the impact of preterm delivery. In that study, nearly 55% had preterm births before 37 weeks, and over 35% of babies had low birth weight, under 2,500 grams. Fetal mortality, thankfully, was much lower at 1.5% in that cohort.
Those prematurity and low birth weight numbers really highlight the consequences, even if survival rates are good.
They do. And the notes mention other studies, too, one from 2020 confirming increased risks of low birth weight and neonatal mortality, and another from 2018 looking at factors linked to worse maternal bleeding, like anemia beforehand, low platelets, diabetes, using magnesium sulfate, or needing general anesthesia.
So other health factors can compound the risks. How does this fit into the bigger picture of maternal safety? The notes mention UK mortality.
Yes, they provide context. The overall UK maternal death rate from hemorrhage is very low, 0.58 deaths per 100,000 maternities in the 2016-2018 report. But within that tiny number, there were 3 deaths directly linked to complications of placenta previa, or the even more invasive placenta praevia, during that time.
So while modern care makes death incredibly rare, it's not zero. The potential for life-threatening bleeding is still there.
Precisely. It underscores why it's taken so seriously.
Okay, so to kind of summarize the potential negative side, what are the main complications listed in the notes?
Well, the biggest one is severe, potentially fatal hypovolemic shock from hemorrhage bleeding during pregnancy, labor, or postpartum.
Right, bleeding is the main enemy.
Then there's the increased risk of venous thromboembolism, VTE blood clots, particularly if admission to hospital is prolonged, which is why they mention considering prophylactic anticoagulants, blood thinners, in some high-risk situations.
Okay, clot risk due to immobility sometimes.
And they reiterate the risk of the placenta accreta spectrum, accreta, increta, pacreta, where the placenta invades the muscle wall, sometimes right through it. This is a really serious complication, often requiring complex surgery and hysterectomy.
Definitely need to be aware of the accreta risk, especially with prior C-sections.
For sure. And finally, for the baby, the potential complications listed are hemorrhage, if fetal vessels are involved, prematurity and all its associated issues, intrauterine asphyxia, lack of oxygen, or birth injury.
Okay. Wow, we have covered a huge amount from these notes. We've defined it, looked at the risks, even if the cause is unknown, understood the mechanism of bleeding, the differentials, how common it is, the key feature of painless bleeding, navigated the diagnosis with ultrasound, the grading, the management from observation to emergency C-section, the prognosis mostly good, but with significant risks and those potential complications.
It really is a condition that requires vigilance, careful planning, and often multidisciplinary teamwork. The notes give a really solid, high-yield overview of everything you need to consider.
They really do. And thinking about it, particularly those risk factors like previous C-sections and how that history impacts the likelihood of the placenta migrating or not, it really makes you pause and think, doesn't it? How much does knowing a woman's detailed obstetric history change how we approach risk assessment and surveillance in her current pregnancy? It highlights just how personalized obstetric care needs to be.
It's a perfect example of that. History is paramount in predicting risk.
Well, that was our deep dive into Placenta Praevia, pulling out the key information from these revision notes. We hope breaking it down like this has been helpful for you, whether you're studying or just wanting to understand more.
And if you are revising, perhaps for the MSRA, or want more resources like this, definitely check out pastthemsra.com.
And freemsra.com as well for more resources. Thanks for joining us on this deep dive.